Hi CTSNet viewers, I'm here with Gianluca Torregrossa. Gianluca Torregrossa is the director of the Robotic Cardiac Surgery program at Lankenau, Philadelphia. He is also very much specialized in the field of coronary surgery and of course coronary robotic surgery. So hi Gianluca,
Thank you,
welcome.
hi Lorena. Thank you so much. I'm a privilege for me to be here. I'm a big user of the platform of CTSNet. I love to watch the videos, to learn from everybody. So thank you for all of the work that you guys do for all of us cardiac surgeons around the world.
So I wanted to start with what are the role of robotics in cardiac surgery?
Yeah, so we are seeing a renaissance in the robotic interest among all of the world about cardiac surgery. Robotic up to a couple of years ago was very rarely practiced, and there were a lot of conversation about what is the added value. Nowadays, with this trend shift towards minimal invasive surgery and realizing that minimal invasive surgery in selected patients is a great option to keep maintaining the great outcomes of a cardiac surgery and widespread to a large majority of patients, robotics comes as the platform from which you can build a series of different techniques that can be offered to different patients. While minimal invasive is a great achievement and we should always compliment every minimal invasive surgeons, robotic is even a step further. Robotic is that platform that allows you to pass from robotic mitral to robotic coronaries, performing a robotic advanced management of atrial fibrillation up to congenital aortic valve. So a platform from which you and your team can build a series of different procedures. And that's the added value.
Okay, so you're just talking about the value. What is the value of robotics in CABG?
Coronary is really where the robo, in my opinion, has still a lot to say and to be used for. There are four major values of robotics in coronary surgery. First of all is that we can offer coronary artery bypass grafting to a large majority of patients. The limit of a sternotomy, and I'm thinking about a very big size US patients with a BMI greater than 60, obesity. Yeah. I'm thinking about offering two mammary arteries to all comers, even patients with an HbA1c greater than 8 or greater than 10, right, where the risk of wound infection is extremely high. Second is that robotic associated with a combination of stents can really offer a complete revascularization to patients in an hybrid form. Finally, the concept itself of complete revascularization in the current era is changing. The era of a CABG times 8 or CABG times 9 is gone. We have learned that putting a vein to every 1 millimeter vessel of the inferior or lateral wall probably doesn't have or doesn't add a much value. It's better to offer a multi-arterial bypass grafting to the best targets. So there is a large majority of patients, not all of the patients, but a large majority of the patients that could benefit from a different type of procedure. Two mammary artery deployed to the left side, off pump or on pump with a chest close without opening the chest. And that is where the value of the robo can come. Alternatively, I can tell you that a lot of patients that would rather receive PCI will come now to me or to my center or to other people who offer robotic CABG because the cardiologist buys in the concept of hybrid revascularization. Patients that are young and that instead of receiving a stent to their middle AD, they can now receive the best added value that is a Lima to the LAD.
Lima to LAD and them venous or no, a stent to the right side.
Correct,
right?
Stent somewhere else or even in an isolated form.
Perfect.
And that is where the added value comes.
Okay. What about training? Because robotics seems like far away from every training center.
Yeah.
So how many years do you need? What are the steps that you need to go before?
Yeah.
Is there any specific tip that you could say to our viewers that are interested in doing this training? Where to go? I don't know, robots that are they different? Do you need different trainings to specific robots?
Yeah, This is a very excellent question, and I get to this question here at EX a lot from a lot of people. A lot of people want to embrace themselves or their team into a robotic program. How and where do I start? We do not, and we lack in Europe and even in the United States of a proper formal training dedicated to robotics. There are some centers that are offering robotic fellowship, and there was a beautiful paper published recently by the team at West Virginia around the value of and where to receive this type of training. I would say that the first things to do is try to be a good cardiac surgeon. Try to learn how to do cardiac surgery. The robo is not the tool that allows you to have more patients. You first need to be a good mitral surgeon, understand mitral, excellent understanding of what is a mitral valve repair. Then you can advance towards a more minimal invasive or robotic. You need to know how to do a bypass before you can think to sew with an 8-0 or a 9-0 in a closed chest on a beating heart. So you need to acquire skills that are your fundamentals. Then you can advance. In my training, I did a special fellowship for 2 years at University of Chicago with Dr. Sam Balke after 3 years in which I was an attending. So I spent sometimes as an attending. I put the cases under my belt. I had sternotomy cases done, and then I advanced gradually. There are different ways to reach the same final results. I can tell you that start to take down a robotic left internal thoracic artery, observe around the videos, get to know exactly every movement. Spend time in your hospital with other robotic surgeons, the urologist, the OBGYN, the general surgeons. They have a lot of tips to teach you, even what is docking a robot, what does it mean, how to put a trocar inside. So we need to cross-culture ourselves, even within our own institution, if you don't have the opportunity to take a dedicated time. There is a lot of opportunity nowadays to learn online and within our institution from other specialties. Third, be very passionate, dedicate yourself to this, take your time. It's never about how long it takes, it's all about the outcomes of your own patients. Don't be afraid if you have to have a conversion. A conversion is not a failure of the surgery. The failure of the surgery is not recognizing that you have to convert and put the patients in trouble. That is what we call failure to rescue. You don't have to failure to rescue the patients. If you understand that you reach a certain time and the patient has a certain complexity that you didn't expect, you should convert on time. And if you can find a mentor and someone that can proctor, will be the ideal and best things. And there is a lot of surgeons in the US and in Europe that are really willing to travel, come to your center, and help you with your first cases.
Yeah. So we've been seeing different robots coming out. Are they different? The training needs to be different if the robot changes, sure, or is the same training?
At the end, it will be the same training. And I can tell you that all of the different platforms that now will challenge the Intuitive that has always maintained their own role as the only robotic company will become to a different game. The game will probably see different companies taking different areas and different anatomy. There will be the robot dedicated to urology. There will be another company that will do mostly thoracic. That's where I think the future will probably handle to. I believe that when you learn a robotic platform, the technology advancement of the other one will be very easy to be incorporated or adapted to your own skills. So you shouldn't be worried to start with the wrong platform that somehow will have a successor or will have a different type of technology. Start with what you have in-house. Try to get acquainted with it, even if it's not the latest Intuitive model. Intuitive is making great step forwards to coming back into the cardiac world with a DV5, and we are waiting for them to prove with a coming out of a stabilizer for coronary surgery, and we hope so. But other companies are on the edge. There are already Mantra, SSI has done already several TCABs and numerous cardiac procedures, including mitral valve in India. The future is at the gate. The young generation of our surgeon needs to be involved and needs to be passionate, spend times and train even with specialties that are not cardiac to learn how a robot works. Learning even in the abdomen is a great school that can be done in your own personal centers without traveling.
Is there any place for mid-cap or minimally invasive techniques when you are doing all robotics? Or?
I absolutely think so. You will never hear from me that is robo versus minimal invasive. I'm here to say whatever minimal invasive techniques you want to embrace, you should embrace. If you come from a center with a long history and a great training and a great volume of mini mitral, that's a great surgery, and you should learn how to do it. It's not that the robo is better. For sure, robo offers a series also of potential technologies that in the future, with the application of AI, imaging, integration of imaging, will give a different platform. But for now, the culture should be become a safe surgeon, become a good surgeon, become an expert in a field of the world of heart surgery, and adopt a minimal invasive.
Thank you so much for being here and for having all the viewers knowing and learning about your experience and how to train and what is the future, the present. We are hoping to have like a webinar and a guest editor series of robotics coronary surgery.
It will be a pleasure to attend.
Yeah.
Thank you so much.
Thank you.
Thank you.
Goodbye.